Thank you all for coming along. We've got two great patent seminars this term, and we're very lucky to have Kevin Outterson, who's a professor of health law and many other things besides at Boston University. He's currently at Chatham House working in global health security. So, thank you very much.
And if you need to refill your glass, welcome to come on up. It won't offend me at all. I've been at Chatham House a couple of months, working. I'm on sabbatical on the project that I'll describe at the end. But really, this is a project that started with a footnote. I was writing an article on, it's called Pharmaceutical Arbitrage, just kind of a theory piece on how pharmaceutical innovation works through the patent system. And some of the key elements of it was that obviously without patent law, it's difficult to exclude people from your inventions, the non-excludability condition, and therefore we have patent law. But the second one is just that the information, the knowledge, once you're done with the patent, once the patent expires, or even before, it's not rivalrous. Many people can share the information if we all understand a mathematical equation. It doesn't diminish the mathematical equation for the rest of us. And I was just describing this briefly. There's a large literature on it. But I dropped a footnote that this isn't true, of course, for something which might diminish with use, such as antibiotics through resistance. And that footnote just bothered me for long enough that I got started in this project, started back in 2005, and it proceeded from there. Some of the funding, lots of money from different people. None of them tell me what to say. In fact, some of them would like me to be quiet, but I don't. The project is called the Legal Ecology of Resistance, and this is a busy chart. The slides will be available, but basically look at the two columns. The first column is conservation. So what can we do to conserve antimicrobials? Things like regulations to prevent inappropriate use, or maybe intellectual property on ways to save microbes, to save the antibiotics. The final column on the right would be production-oriented incentives. How do we create new drugs, and whatnot? And then the rows are various legal interventions: property, regulation, contract, and tort. Most of the activity in this space has been in this sector 2, right up here, the production and property sort of sector. Intellectual property law. In other words, using patents to incentivize the production of new molecules. The idea here is that there's 7 other sectors that can intersect in this area. And some of what this work does is to move outside of box 2 and to try to expand things into some of the other boxes. All right. Some of the hypotheses that our research group has looked at over time, and I'm just going to mention a couple of these, and we'll see these through today's presentation. But the idea of patent holder waste. And so this is that the patent holder, knowing that it's a time-limited property right, they only have 5 years left on the patent. They're just like the person holding a life estate on a manor, and they're not willing to maintain it, or maybe they're going to cut down all the timber and carry it off. So in 1256, the Statute of Gloucester here in England, created this tort of waste, which said that the person with the time-limited property right couldn't destroy it, couldn't waste it during the last couple of years before they had to turn it over to the remainderment. So is there a possibility that patent holders are wasting this time-limited asset? The flip side, maybe what they're doing actually is taking care of it during that period. Maybe what they should have is they're conserving it. Maybe they should have a perpetual patent, which has been something that Eric Case has suggested. And then the various other hypotheses, some of which we've tested, many of which still lack empirical verification at this point. So what I'm talking about today is, you can call it antibiotic exceptionalism, why antibiotics are different and why the intellectual property rules should or could be modified in this area. And these are the 6 things that we're going to talk about in order: rivalry, innovation, how you do valuation, the boundaries of patents in this space, what the role of generics, the value or disutility of generics, and just the whole concept of competition. And the little tiny print is a bunch of articles that I hope that you'll read and cite, most of which were written by me and my friends. Okay, so rivalry first. When you have a drug like Lipitor, the billionth dose is still just as effective in the human body as the first dose ever was. So there's not rivalry. I'm not talking about the pills, I'm talking about the effectiveness of the chemical. There's not rivalry with most other things in the pharmaceutical medicine chest, but there is rivalry with penicillin. Penicillin saved a lot of lives in World War II. For some bacteria, they're still fully susceptible to penicillin. Group A strep would be a good example. But for many others, penicillin is no longer effective. So with each use of an antibiotic, and to a slightly different extent, antimicrobials, antiparasiticals, antifungal agents as well, but I'm talking mainly about bacteria, it diminishes its usefulness. And so there's a negative externality is one way to think of it, this rivalry is another way to think of it. But how does this change how we think about this area? So this is from the Centers for Disease Control. They showed 23,000 people dying a year from multi-drug resistant bacteria in the United States, which purports to be a developed country. And then another 14,000 people dying from Clostridium difficile, which is an antibiotic-associated disease. Europe has roughly similar numbers. So there's a lot of people dying in advanced countries from these conditions. We don't have great data on the number of deaths in the rest of the planet. So it's this huge problem. The rivalry actually kills people. This is an example of intellectual property, with a real impact potentially on human life. But not just the people that are dying from multi-drug resistant diseases. If you talk to the Chief Medical Officer for England, Dame Sally Davies, she'll tell you that medical practice today would be very difficult without antibiotics. So chemotherapy, complex surgeries, all the things on this chart, and many others, you just wouldn't do or couldn't do to the same extent if you had no antibiotics available. Would you do a total hip replacement? Probably not. Not unless their life depended on it, because opening the person up and putting something into their body like that may very well kill them. So not only is it there an effect on people dying from multi-drug resistant bacteria, if we didn't have antibiotics, modern medicine, or at least a large chunk of modern medicine, would become much more dangerous or perhaps impossible. So the stakes of rivalry in this area are indeed high. The second point about innovation. There's debate on the role of innovation, the patent system in innovation. If you talk to software people, they say it has no positive effect, right? But most would say that in pharmaceuticals is probably the best case for patent-based innovation actually working. And so here I'm going to present evidence that that's not necessarily true in antibiotics, and why might that be, and what could we possibly do about it. So this is a famous chart by Brad Spellberg, Job Powers et al. In clinical infectious diseases, showing the decrease in new molecular entity antibiotics over this period. It's a pretty bad trend line, wouldn't you say? The trend line looks like it's going negative anytime short. I don't know what a negative antibiotic introduction looks like, but this is not a happy chart, okay? And so, people have said there must be an innovation problem here. So we went back, our group and Boston-based group, and looked at all these new molecular introductions for antibiotics, but also for antifungals, antivirals, and in addition. And we backed out. This chart here just shows we can do it by a decade, we can do it by a different period. And you see that the blue is really what was on that previous chart, antibacterials. And the red are antiviral and antiretroviral, and the green are antifungal agents. So one way of seeing this is what happened was that there was a shift in the 1980s. We had a tremendous increase in innovation, not in bacteria, but in antiretrovirals. And why was that? It was a natural response to the urgency of the AIDS epidemic. And a lot of money and energy was shifted to those fields. So this chart says, well, maybe it's not as big of a problem. It was actually science responding appropriately to societal fears, needs, and demands. Okay. This chart is a little different. You'll notice at the top we say systemic anti-infectives not withdrawn. So what we did is we looked at the 61 antibacterials and 111 total anti-infective agents over these 3 decades, and looked at the ones that were still being marketed. In other words, we took out the drugs that were withdrawn, mainly because of either disappointing commercial sales. For 6 of them, there were clear safety signals. In other words, we took out the drugs that were duds, that never went anywhere or had significant safety factors. And when you look at it this way, it's a much different innovation picture. Even for bacteria, 13.13.9, really what was happening in the previous slide was that there was a lot of terrible antibiotics that were introduced in the 1980s that never did anything helpful. And once you back those trashy, ineffective antibiotics out, the innovation picture looks significantly different. This is now, we've taken that same data, and this is by year, and this is marketed drugs, so the withdrawn drugs are gone, and it's just antibiotics, antibacterials, no antivirals or retrovirals or fungals here. And it's still a downward trend. The linear trend is still downward. So this is not an entirely it's a happier story, but not an entirely happy story. But the question is, the one definition of insanity, if you keep doing the same thing and it doesn't work, there's something wrong with you, right? You're not learning from your situation. And these arrows that are coming down are each patent-based or patent-related incentives that have come in. So the Baudot Act, the Court of Appeals of the Federal Circuit, the Orphan Drug, the U.S. Canadian Free Trade Agreement, the TRIPS Agreement, listing antibiotics in the Orange Book, pediatric exclusivity, BioShield, and I could add the GAIN Act on the far right, which is relatively new. All these interventions are still a downward trend. So, you have to ask, maybe something else is going on, or maybe we need to try something entirely different in order to address this issue. So we took all the data. This is not just anti-infectives, but every drug introduced over the 3-decade period and looked at by decade by their ATC class. So which part of the body is it addressing? And you see some interesting things here. It's not just antibiotics that have had decreased innovation over time. There's other sectors. And most notably, if you look at cardiovascular, in the 80s it was 18% of introductions, down to 12, then down to 7. I put this data on this chart. It's the same data, just spread out over each of the 30 years. And so here you see the same downward trend for cardiovascular drugs. So what's, is there something uniquely wrong with cardiovascular drugs? Part of the issue there is that Lipitor is really effective. And like I said at the beginning, there's not rivalry. And so any new drug in this class has to beat Lipitor or beat some of the other effective generic drugs which are already there. So there may be secular trends going on. There may be other stories that could be told. So one of the stories is told that I'm obviously going to immediately debunk, because I call it conventional wisdom. That's always kind of a straw man setup, right? That there's something unique about antibiotics, the short course of treatment. You only get them for a couple days or 2 weeks at most. Sometimes for prophylactic use, for surgery, you get a big dose, 24 hours, and you're done. And so that's, there's at least a dozen medical journal articles in which this is suggested to be true, never with actual evidence, okay? So I think it's not the problem at all. And the counter argument that I use is that, look at this. This is chemotherapy. Chemotherapy is typically a short course of treatment. And look at the innovation story for chemotherapy. So what is different? Is science just easier with chemotherapy? If you talk to the oncologists, they would say, no, that's not true. What do you think the difference is between chemotherapy and antibiotics and cardiovascular, for that matter?
Price.
What?
Price.
Absolutely. These are the drugs that you hear about on the news, and we could write a story about Hep C in 10 years, right? Being sold to the national health system or to insurers in the United States for $100,000 US per course of treatment. And they may give you 6 to 8 weeks of disease-free progression, really modest clinical impact, huge financial. Of course the companies are chasing it. So this would mean that maybe the problem here is not patent law, but it's actually reimbursement. It's how we pay for these things. And we should look at reimbursement-related issues instead of patent-related things. So reimbursement would be right here. Contract production. So prizes, grants, value-based reimbursement supporting new antibiotic production. So that moves the question from that, box 2 to this box 6, something like that. So at least that's where the work is progressing at this point, trying to look at reimbursement-based, contractual-based things, both for the production side and the conservation side. I'll talk about that at the end if we have time. That's the main focus of the work right now at Chatham House. Okay. Third issue, valuation. There's a lot of things that are strange in the valuation world. So normally when you have a patent, how do you value it? Well, you go to market with it and you see what the world is willing to pay for your product. So it's a market-based valuation. It doesn't require the government guessing or some experts. You get the valuation by selling it to the world. But here you have this unique situation which, all the clever people, the doctors and hospitals and whatnot, are trying to undermine the value of your market, because the best clinical practices makes your molecule less valuable. So MRSA, big issue, big problem, $1 billion plus sort of market. But in the United States, and if I showed you data from the United Kingdom, it's even better. Look what's happened from 2005 to 2011. The national burden of invasive drug-resistant MRSA is going down. Why? Because hospitals are working hard in infection control and hospital epi to prevent this sort of stuff. So think about bringing something to the market. It's really valuable. It has lots of insurance type value to the system, to society, and yet many resources in society are dedicated, feel a mission to make your molecule less valuable, right? For all the right reasons. So that's the situation the companies find themselves in. Best clinical practices undercut the market. Okay. The second quandary is that there's all sorts of incentives across the supply chain to do the wrong thing. If you're, and this is true in many settings, but if you're a doctor in the United States and a patient comes to you and wants an antibiotic, if you don't give it to them, you might get a negative score sheet. All the doctors are being rated these days, and they may get a 2 instead of a 5, and that impacts the physician. In the developing world, a lot of these antibiotics are sold in informal markets and with people not necessarily trained. And that's how they make their money, is by selling them. In hospitals in China, at least historically, hospitals and the physicians may have been under-reimbursed, and they made money by selling drugs, prescription drugs, not just antibiotics. In hospitals in Niger, they don't provide the antibiotic. If you're going to have an operation in a public hospital in Niger, they give you a list, and you run across the street and buy it. So is there any incentive for the physician not to load up that list? Maybe there's some sort of a favor that's returned from the people that sell it. And it's all sorts of financial incentives across the system to do the wrong thing. If you're the company, how do you make money? By selling the largest volume at the highest price. And I'm not saying necessarily the companies are pushing antibiotics just to make money, but the financial incentive is set against what's the best clinical situation, which is appropriate use, not necessarily the highest amount of use. Third issue is that the expected net present value, abbreviated here ENPN, for antibiotics are really quite low, partially because there's an overhang of inexpensive generics out there. And so they're underinvesting in the sector. And when they do bring a new antibiotic to market, they have a reason to go for an antibiotic that will treat a lot of people for things like earaches or upper respiratory infections, which many times are viral. MRSA would be a category these days. Broader spectrum agents, complicated skin and skin structure infections. What they don't necessarily bring an antibiotic to market is the thing that's actually scaring Dame Sally Davies, in which you read about, the gram-negative carbapenem-resistant enterococci. Those types you rarely see anyone bringing to market because the market is so small. There's so a small number of people there. So we took a look at, this is for a study for Health and Human Services by Eastern Research Group I'm a consultant on. We looked at the expected net present value. The FDA asked us to look at these 6 conditions: hospital-associated bacterial pneumonia, complicated urinary tract infections, and 4 others. Okay, and you'll notice this is the expected net present value for the company, up to $200 million. This is within the arrow bar for urinary tract infections. But the thing you should notice immediately is that within the arrow bar is a 0 net present value, and this drives the company. People say, yes, that's exactly why. We're having trouble funding any of these projects internally. We run the same numbers and show a very narrow or negative net present value. This is a problem, right? It's not necessarily a patent-related problem. We modeled and showed that if you added 5 or 10 years to the patent at the out years, year 21 to 30 or something like that, it's a very small effect because of discounting in the time horizon. Really, what the companies need is money up front. They need money during the clinical development period or money in the early years, not money in the out years. So we have a severe problem here with the way innovation works in this sector. Companies can't raise prices because there's generics out there that are still relatively effective. We also have problems with the difference between the social value and the private value of antibiotics. So again, if we don't have antibiotics, we can't do surgeries like this. The social value of antibiotics is part of the IMI, European Union funded project to try to lay that out. It's bound to be something in the range of hundreds of billions of euros or higher. Because you think about what would be the impact of returning to a pre-antibiotic society. It's huge. Social value is huge in this area. The private value, however, is relatively small. The private value aggregated across the planet is about 30 to 35 billion. That's what we pay for antibiotics. The private value at the point of sale, at least in the United States, the Publix grocery stores give them away for free, right? You can come in and you get a free antibiotic because they want you to come into the store and to buy bread and milk. Walmart charges $4, which is no better. So we have this huge mismatch between the social value and the private value. of these drugs, and the companies can't raise the prices sufficiently to close that gap in any meaningful sort of way. But if you're making money on unit volume times unit price, if you can't raise unit price, you try to raise unit volume. They can't do that ethically in this space because of resistance. If you have a beautiful molecule, something that's fabulous, that works against gram-negative pathogens, what's going to happen is you're not going to sell very much of it in the first decade. That's a bummer business model. It's difficult. You have the best car, the best computer, laptop. Sorry, we're only going to sell 10,000 of those. If the iPhone came out and for the first decade, only 1,000 a year. That's the sort of thing drives the companies crazy in this space. It makes sense. You want to conserve and protect these new molecules, but from the company's perspective, is a disaster. NI is non-inferiority. The way that we do clinical trials for antibiotics results in the way that we have the definition of inventive step in this space allows all sorts of closely related antibiotics to come into the market. That's true across all of pharma. But for antibiotics in particular, it seems like we get a raft of them with limited safety and utility data. And so this is some data also from the withdrawal study that our Boston group did. And so 61 new molecular entities over 3 decades in antibiotics, and 26 of them were withdrawn over the period. That's triple the rate of all other. We looked at every other drug category in the United States. It's triple the rate. Very few of these had any sort of marker of quality status, like prior review. Most of them were fluoroquinolones or cephalosporins and were follow-ons. So Bayer bought ciprofloxacin, and then there was all these others that tried to steal the market from Bayer and never went anywhere. And 6 of them had safety-related withdrawals, which is relatively rare. Okay, we got a lot of trashy innovation, Me Too's that were actually dangerous because they promoted resistance as well as being ineffective. If they were simply ineffective, we'd only be wasting money. But if they're ineffective and they promote resistance, then we got a real problem. Okay. This is one that drives people crazy, but resistance is too slow. Okay, if resistance was really fast, then it would destroy a drug right about the moment the patent expired, and the companies would have a better ability to sell because the patent would generic would go. But actually, there's a lot of drugs for which resistance is not significant. Penicillin G still sells a lot. 7 decades on. Sulfa medicines, the original antibiotics from the 30s and 40s, still sell significant amounts. Vancomycin, the most widely used hospital empiric antibiotic, at least in the United States, entered the market in 1958. So resistance is paradoxically too slow from an innovation perspective. It would be better for innovation if resistance was more powerful and ate up the drugs more quickly. And everyone is underinvesting in this sector, including the NIH, and the data from Europe is similarly bad. So this is antimicrobial research for resistance. This would include antiviral, retroviral, and whatnot. If I had just bacteria, it's a much worse chart. So it's a negative slope. We're spending less as time goes on in the United States. Europe, it's a significantly lower base amount as well as being a negative trend line. So we have problems in this space. 4th out of 6 is boundaries, and I'm thinking here, of Moyer and Beston's book on patent failure, and they describe one of the problems in patent laws is fuzzy boundaries, and we wish we had tighter boundaries. And an example of an area with fuzzy bad boundaries would be business methods and software and whatnot. And the only area with good boundaries, according to them, are chemicals, pharmaceuticals. But in antibiotics, we have boundary problems too. So one of the problems is that this is innovation in science, that resistance actually doesn't limit itself to the molecule, both through horizontal gene transfer and also just the way that resistance emerges and the types of mechanisms. You can have resistance that spreads between pathogens, across pathogens, and within class and across class. So you could have a totally valid patent on this molecule and somebody else have another valid patent on a different fluoroquinolone. And the second one could cause resistance to the first. Or you could have a molecule that was a completely different class and it causes resistance. Another way to think of this is negative externalities or pollution-type externalities that inflict damage not only on nearby molecules, but even other fairly distant antibiotic molecules. And all of this differs by bug-drug combination. So it makes it really hard to coordinate or to do anything effective on a molecular basis. Another way to think of this is that everyone has property rights that are like overlapping. It's almost like a condominium type situation in which the property rights overlap each other in multiple complex ways. And also, even if you have a distinct property right at the beginning, you bring a molecule to market, and your understanding of that molecule is that it's a new mechanism of action and nothing else is resistant to it, you may find 3 or 5 years into it that something else does cause resistance to it. So the property boundaries may become more indistinct as time goes on, depending on the science, and it could differ dramatically by pathogen and by molecule. So it really makes it difficult to exclude free riders, and it makes it difficult to really control what's going on with your product. So the reason why we look at ecological models here is that if ecology sees all these interrelationships between different things that live together in community with complex interactions, and that's really what we have in this space. Is really not a single molecule, surrounded by a moat and a castle. We have a complex ecology. Scientifically here, and so I want to play out a few legal ecological sort of analogies that might be helpful. So the three I want to look at are pollution, common pools, and microbiome. So pollution, this happens frequently, at the hospital level through transfers. So a hospital may have a great infection control program, but if the long-term care facility, which admits patients to them, doesn't, then that transfer brings resistant bugs and pathogens to them. It actually increases costs on your competitors or on the other elements in the system. The fact that a long-term care facility is being sloppy increases the cost to the other people in the system to which the transfers occur. Patients can transfer, physicians can transfer, healthcare workers can transfer. The most dangerous place, I think, in a modern American hospital is probably the radiology room, because all of the sick patients go down there and lay on the same bed and get a CT scan. And is there really anybody who's wiping that down with Clorox after every? I don't know. So you can isolate patients with MRSA, but if you don't have separate dedicated all these other facilities, then who knows what you've done. So I want to think of this, think of watersheds in terms of pollution. And an important moment in water pollution control is to think about all the different sources that contribute to the pollution in a watershed. We're now starting to map germ sheds, the complex social interrelationships which cause resistant pathogens to share and to interact. And so the legal tools are going to be different. They're not going to be IP, they're going to be regulation, liability rules, contract, maybe tradable permits, which I think, I can't get my mind around that. But this is data from Susan Hang's group out in Orange County, California. Donker here in Europe has similar work that he does both in England and in the Netherlands. So these are 32 healthcare facilities in Orange County. She got all of the data on the movement of patients with resistant bacteria between all 32 over several years. And so if you're a hospital 32, facility 32, you're relatively isolated. But these facilities just have a huge number of patients coming in. And each of these colors represents one of the other facilities, and they can also show it in a circular diagram with all the arrows. But these facilities have huge amounts of inbound, transfers of patients with multi-drug resistant pathogens. And so this is a map, or the beginning of a map of the germ shed amongst healthcare facilities in Orange County, California. You could do this everywhere. In fact, Donker's work has done it for the United Kingdom. All the hospital trusts, all the hospitals in the whole country. He's got this beautiful chart. I should have it up there, but I don't. Okay. So there's this pollution idea, and one of the other thoughts here is that you also get pollution from the animal use of antibiotics. So Bayer sells their drugs not only for humans but for animal uses. And recently, Aidan Hollis, an economist from Calgary in New England Journal of Medicine, has proposed a Pigovian, a user tax on the animal uses to try to take away, to account for some of this negative externality. But you can go look at that. The second ecological model is common pools. And so think of antimicrobial susceptibility or effectiveness as a valuable, exhaustible resource with uncoordinated withdrawals. Anyone can take from it. Just you take the pill and you've made a withdrawal. So it's a pond stocked with fish, but anyone can fish there. Some people can fish with hand grenades, Some people can use seine nets, and nobody's responsible for restocking the fish or putting minnows in, or for, what would happen to such a pond? What would happen to such a pond. We have huge potential gains from coordination in this space, but there's not much coordination that's going on currently. So fisheries and buffalo are examples. So here's that negative chart again. And you can see the same negative chart with cod. So, peak cod, 1970, right? And it's been downhill since then. And so what should we do to reverse the decline in cod production? How about aggressive intellectual property to make the cod fishing boats more powerful? You can see how that would just not work. And yet for antibiotics, some of the responses are, let's make antibiotic patents stronger, more powerful, more remunerative, longer. But if you're dealing with a common pool resource, it's exactly the wrong thing that you want to do. One of the ways out for cod was to do aquaculture, to farm it, adding to the pool instead of just making withdrawals, easier to do. The chart again. This is buffalo, and this is Taylor's, he's an economist in Calgary. And peak buffalo was 1875 in the North American plains, according to his imputed data. And again, if you're right about here, do we want better patents on ways to kill buffalo? Should we put Sarah Palin in a helicopter with machine guns to kill buffalo? That wouldn't help because the actual herd is diminished. So you need to do something about the ecological situation in order to replenish it. So the business model before, when buffalo were abundant, was this, and after 1870, after the Civil War was over, people would get on trains with guns. This is a postcard. You can't see it very well, but everyone here has a rifle, and they're just shooting the buffalo. Things changed. There was technological innovation, which totally decimated the herd. So this is hides piled up for export to Europe. These are skulls. You can't see them very well, but each of those little round things is a buffalo skull. We killed a lot of buffalo at the time. And as a result, you have to think, what is the model here? And this is moving off to energy for a bit. Is it fossil fuels or something that's more sustainable? Okay. So thinking about this as a sustainability issue is important. The third ecological model is to talk about microbiome. Okay. So these are hand sanitizers. You probably have them around. What does that do to your hand? I mean, let's say that it's 100% effective and it wipes out every microbe on your hand. Is that a good thing? I mean, do you know what's growing on your hand? And maybe a lot of it is not pathogenic. What's in your body? Do you really want to wipe out all the microbes in your body? The mitochondria in your DNA came from a bacteria. Do you really want to wipe that out? I think life would be difficult without your mitochondria. So we have to think about the microbiome. So this is a complex ecological system. If we wanted to kill the weeds, would we napalm the entire picture? Right? No, you just want to kill the pathogen, not the rest of the helpful things that are growing in the ecology. We don't know what's growing in our ecology. We don't know what's going on in the human microbiome. So since 2007, the NIH in Europe has a similar project as the Human Microbiome Project to try to map everything growing on humans. And they're finding thousands of species that they've never been able to culture because they can do it through whole genome sequencing, most of which either are commensal, or helpful bacteria, or of unknown effect. There's a lot of things. So, if your hand is that nice grassy field, and you totally wipe off everything on it with totally effective alcohol-based gel, have you just prepared something for the weeds to grow? I mean, how do you know that the good things are going to reappear? And so in the United States right now, there's a Clostridium difficile, it's killing 18,000 people. And the most promising treatment right now is fecal microbiotic transplantation, in which you're reestablishing the microbiome of the patient or another patient who has a healthy intestine. And it's actually remarkably effective. And the FDA doesn't quite know how to regulate it yet. Tree of life, we're way up there in that animal thing, and between slime molds and fungi, there's just a lot of life on the planet. And we need to be careful. So this model says, let's be careful with what we're doing. There's a lot that we don't know. We may be destroying a complex ecology. There's suggestions now, and a lot of it is hypothesis generating rather than actual results, that a lot of the autoimmune diseases and obesity and many of the autoimmune functions that you're seeing an increase in humanity might have something to do with what's going on with microbiome. Talk to them in a decade, and we'll see. Okay. Fifth topic, generics. Typically in pharmaceuticals, generics are a happy story. Generics come on the market, the price goes down, everyone's happy. The companies have made their money, they move on to something else, and it's a positive gain for society. Okay? Maybe not so true when it comes to antibiotics. So, here the idea is that maybe having a patent holder, control the product actually conserves the molecule. Maybe having a bunch of competition from low-cost generics might drive up utilization inappropriately. And so that's at least a hypothesis. And so the way side of it, and I've described this already, that maybe time-limited property rights are a bad idea, and these are some of the ways that a company could be exploiting the patent inappropriately during the years. Over-marketing it, selling it for animal uses, we know they do that. Label extensions to non-serious, non-life-threatening things like earache and community-acquired pneumonia. A broad spectrum instead of narrow, and not pairing it with diagnostic. Diagnostics are a disaster for these companies. It reduces their unit sales. Okay? So these are 5 antibiotics, and Zithromax, Cefrin, Cipro, and Zosyn, in the 5 years prior to patent expiration. And it looks like Zithromax, the sales did go up right before patent expiration, but there also was a secular event that year. That was the anthrax scare, and they sold a lot of it because of that. So this data would suggest that if the companies are doing something to inappropriately drive up the sales, they're not doing it only in the last 5 years. Okay? It might be that they're trying to do it across the entire patent term. This is indeterminate on the larger question of patent holder waste. The next 6 or 7 slides are different antibiotics and showing what happens when they go generic. The darker blue being the branded sales, the other blue being the generic sales, and these are units, not dollars. So for each of them, you see a remarkable increase in this. Well, amox would be different, but you see a tremendous increase. And so you might say that generic entry caused. You can't say clearly generic entry caused an increase in the number of units sold. Okay? What we don't know is whether those increased units were appropriate. Are they treating actual clinical disease? Are they being used in a place like India that's under-treating bacterial disease? Did they drive resistance for a good reason or for a bad reason? So still, all the data in this area is very indeterminate. More funding needed. At least that's what I tell the people that write grants. The 6th one, competition is short. So competition law in the United States, antitrust law, I think should be different in this area. So competition in this area might drive socially inappropriate things. So the things I've talked about before. Competition might be a negative social factor here instead of the invisible hand doing good. And if you're going to do the right thing by these molecules, because resistance crosses class and bug-drug combination, you might need all of the companies involved to actually work together. Normally we would call that a conspiracy to restrain trade and try to put those people in jail. In this space, you might need the 4 or 5 companies left to do antibiotic work and all the generic companies and the public health authorities to actually work collectively to control supply and demand in the marketplace. To a competition person, this sounds like a terrible idea, but it might be what's appropriate clinically for antibiotics. You're not going to be able to do it by drug class. It's not going to be like a fluoroquinolone cartel and a beta-lactamase cartel. It might be all bacteria because of the cross-class issues. And different story with other pathogens, because the science is different in bacteria versus viruses versus fungi versus molds and parasites. So, don't assume that anything carries across to any of the others. Okay. I was going to pause here. This last bit is describing, given all these problems and all this unhappy story, what should we do? And so what's happening in Europe is that there's a major project, €6 million being funded by the European Union through the IMI, over the next 3 years to try to look at devising a new business model for antibiotics. And I'm part of that project, and if we have time for that, I could show kind of where things are going and just some of the preliminary thoughts. Is that okay? Okay, all right. So the process so far is there was a Chatham House roundtable on October 13. We looked at 9 models, 9 delinkage models, which would sever the relationship between the patent owner and how reimbursement is paid to them. It's no longer a volume-based effect, but you're being paid on a prize or reimbursement type basis. There's a working paper which a lot of us worked on. It's on the Chatham House website. You can go find it. And that's what we've done so far. And in that paper, we looked at different delinkage models of prize funds, a health impact fund for antibiotics, a strategic antibiotic reserve. This idea that if we have, today in the United States, we take petroleum and bury it in the ground. Why, in case there's another Arab oil embargo or a war, we'll have oil. And so the idea is maybe if we find a wonderful molecule, what should we do with it? We probably should lock it up and use it only in the rarest of circumstances and save it for a time of greater need like a pandemic. So all of these are different models, and you can go read the paper, but they have different approaches, whether they're more globally focused or focused on a nation, and whether the intellectual property is owned in the public space or in the private space. And so there's a variety of models. GSK is the one that GlaxoSmithKline put forward. They're officially in favor of a delinkage model for antibiotics. This working group has been expanded for this summer, which is the work I've been doing at Chatham House, and we've completely changed our approach. We've given up on those 9 models, and we're looking at a functional analysis instead. We're looking at, because a lot of the models overlapped, we're looking at the issues that are common across them and trying to begin to answer some questions about them. And then for the 3-year IMI grant, which hopefully kicks in October, that's what the group 2, work stream 2 will be working on. Okay, so what is delinkage? You no longer get paid for your patent based on sales volume. You get paid some other way. We want to increase incentives. We want to permit coordination, and we also don't want anyone to not get an antibiotic because of inability to pay. So you have to preserve access both in this country and around the world to do it. It's not something that's just going to solve production. So if we threw a couple of $1 billion at antibiotics to create new ones, that's just like pouring more gasoline on the fire, right? You have to do something that simultaneously addresses both conservation and production. So any of these models have to do that. We're going to start in the hospital space. It's easier to look at than the community area. And since this is so complex, we're warning people the solution is probably complex. Biology is complex, and we're probably not going to come up with something that's extremely simple. Okay. So these design questions I'm not going to go through. I'm just going to kind of show them to you. So these are the sort of questions one would ask. And again, the slides will be available. Who's got the best information? Who can change behavior, right? What's going on? Is the low-hanging fruit really gone for antibiotics? If so, conservation becomes more important. Are we at peak oil, right? Then let's do more solar power. Are we at peak antibiotics? Is the science harder to get the next antibiotic? If so, conservation. So macro issues are important here. I'll talk about that later. Okay. So these are the 6 functional elements, and I'm just going to talk about 3 of them. Okay. So how big is the reward, and what does the contract look like? Geographic scope, is it a country, a region, the world? What products qualify? How do you pay for it? And what happens to the IP? And how do you control utilization? So these, that means this is not the group that thinks this. This is Kevin, okay? Because the group's got 1.5 to 3.5 years to work on it. So structuring the reward. I think we know that the social value greatly exceeds the private value. It's at least an order of magnitude, if not 2. Ramanan Laxmanaran's group is going to look at that. So let's just say that we took a 5% boost in global antibiotic reimbursement. It's about $30 billion right now. A 5% boost, it's $1.5 billion US a year. If you paid that to the companies for new antibiotics, or new innovative antibiotics over 10 years, and let's say that, despite the bad past trend, that they actually brought 5 powerful, good antibiotics to the market. That would be $300 million of the prize to each of them per year over 10 years. The companies say that's a gold mine compared to what they're getting today. So, a fairly modest stream of money, 5% of the global reimbursement antibiotics, could actually make it a sustainable product instead of one that may have a negative end. So this is just kind of sketching the sort of numbers that we're talking about. Second thing I'm talking about is product scope. I'm only going to do 3 of these. Is it any antibiotic or just high quality antibiotics? It's almost like, another straw man sort of rhetorical question. We have the history of really bad antibiotics. So, my view is that we need to focus on higher quality antibiotics. There's a law called the GAIN Act in the United States, and it has a qualified infectious disease product list. And this is new in the last 2 years, lots of drugs are qualifying for that list, even though there are not very exciting antibiotics, put it that way. So our recent experience with the GAIN Act suggests that we probably need a narrower list than what the GAIN Act has, because we don't want the sort of incentive that everyone qualifies for. If everyone in the class gets first class honors, you might as well do away with grades. And the thing that is scaring people, it's people like Dame Sally Davies or in the newspapers, is these gram-negative multi-drug resistant infections. So we need to focus the incentive there, not on community-acquired pneumonia from gram-positive sort of infections. The last one I'm going to talk about is financing, and this is kind of how the money would flow. So preclinical is kind of when it's in the university research labs or trying to pick a molecule. Clinical is when you're testing it in humans, and then post-authorization is after you have the patent and you have approval from the EMA to sell it. So we want to put some of that money into each of these three sort of categories because the companies need the money early rather than in year 21 in order to have incentives to do things here. So in the preclinical, it's a public-private partnership sort of model. There's a lot of these, most of them with Gates, Foundation funding. It's actually a model that seems to work. The clinical piece, we're really looking for an orphan drug type model. So orphan drugs, as you go through the clinical piece, tax credits kick in that lower the net cost. Also, there's a lot of effort to streamline clinical trials for antibiotics, which lowers the net cost for the companies. And then post-authorization is the delinkage sort of thing. You normally get paid on volume times price. Now you're going to get some sort of a prize-based, that 150 million, 200 million, $300 million per year sort of prize kicking in. The first one is funded through the same way we currently fund things like NIH or just research. This is funded through your tax system because these are tax credits, and this is the one that would need additional funding that boosts on top of antibiotic reimbursement. You could put a user fee in antibiotics, a 5% fee, and then put that money into that. Okay, so that's all that I have. I know that was a lot, and sure, maybe stirred a question or two. But for the next, like I said, 3.5 years, the IMI project, the Drive AB project, we'll be trying to build out all of these things with a lot of detail and come up with a proposal for Europe that will have all the stakeholders, already signed on to, and hopefully Europe will be able to do something interesting in this area to preserve antimicrobials as a precious resource, so that they aren't destroyed like the buffalo.